Could it be said that in doing all this, you are in effect de-skilling the doctors?
I think a lot of what I've discussed is quite general in terms of the fact that our junior medical colleagues will be seeing, especially the higher risk groups, as part of their intake. A lot of the skills are similar in terms of what we're doing, but anecdotally, that the one thing I think that has been less prevalent for them to do, because we're doing it, is around duration decisions. Because when we see patients at that 3-month point, one of the key things that we do is decide, well, how long are we going to anticoagulate this patient for? And actually, we are doing that almost exclusively within the health board. So what we've actually had is a lot of registrars and even sort of more junior grades of medics sit in with us in clinic, which has been very good, because I've been very keen to learn from them in terms of their skill set, in terms of how they would approach certain aspects, and they've been very keen to learn from me. And again, I think that's been a really positive experience, especially because we're working at this advanced practice level, that we're able to have a little bit of an idea sharing as well, so that we're continuously improving what we're delivering to our patients.
And how did patients respond?
Absolutely. I mentioned earlier that naturally patients who have a PE are going to be very anxious. And anecdotally, what we found is that, interestingly, a lot of the patients who come through the ambulatory pathway are maybe less anxious, because of the fact that often they don't really associate themselves as having an acute serious condition until they're told following the CTPA. The patients who have far more traumatic events and are hospitalized have far greater levels of anxiety, we found. But again, by us trying to offer that prompt follow-up, the anecdotal feedback has been that actually that's been very positive in terms of their overall experience. We offer a dedicated clinic for VT. We have the knowledge of the condition. We're able to sit down with the patient and have a discussion around the diagnosis to help them to understand how the recovery process works. We're in the process of trying to capture some feedback from patients to improve how we offer the service, especially around what information we give them, and how we can try to improve their anxiety levels. And it's a little bit of an in-progress work, but thus far, the feedback has been incredible. It really has. So patients really do seem to respond really well to service, are very appreciative of having that prompt follow-up, of having that sort of week follow-up when we send them home early, and actually feel that the information they're gaining from the service is really improving their knowledge and helping them to understand the condition far better.
Very encouraging. To what extent did this service build on the existing venous thromboembolism service that you operate in Swansea?
I would say it adds an extra dimension to the service that we already have. I think our early work was primarily focused on DVT. As I mentioned, there were PEs coming through, but we felt that we needed to do more work with improving that. We've also, I think, as I've discussed previously, done a lot of work with cancer-associated thrombosis and trying to improve the experience for that. This was the natural next step to ensure that we have a fully comprehensive VTE service, which is addressing all of the most common presentations of VTE and offering a high-quality service, I would say, that's delivering good patient outcomes and is sustainable.
And that takes me on to my last question. What next? Will the service continue?
It's an ongoing service. It's funded to deliver 37 and a half hours a week of VT service. So it's just 5 days a week, 9 till 5. And we have a collection of follow-up and new slots. And like I said, we're taking referrals from the SDEC where we're based. We're taking referrals from the boards. It's an ongoing service. I think what my main priority going forward is actually something I touched on earlier, which is around that framework and that training process, because this isn't something which I found that we can just start doing without any form of training with it. At the moment, I've developed a training program, a competency-based training program, which we're piloting internally, and it's it's quite a lengthy period, actually. It's about 18 months of supervised to semi-supervised practice, so it's there's a lot of skills that need to be gained, and as I said, we've got this competency-based training program so that we can show our competence as time goes by. So from a governance perspective, we have that in place, but what I'd like to do is look at how we can expand that maybe to something a little bit more formal and possibly national, as a sort of training framework nationally for other pharmacists or healthcare professionals who want to do these types of roles, because I'm not aware at the moment of anything at that level to be able to support them to do it. And with that in mind, what we'd like to do is to obviously expand the team locally so that we then have more pharmacists doing it and we have more resilience in the service, that allow us to look at what else we can do in the future then.
Kieron Power, thank you very much for talking to us about the development of this important pathway and the impact that it has had. That really has been terrifically interesting and inspiring. For more information about Kieron Power's work, please visit our website using the links in the description, and be sure to subscribe for more news, videos and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.